Good afternoon. Thank you for joining today's Health Equity Confidential Feedback Reports for Post-Acute Care Q&A session. During today's webinar, CMS subject matter experts will provide answers to some of the most commonly asked questions pertaining to the methodologies and interpretations of the Health Equity Confidential Feedback Reports that were released on October 16th. This webinar will include a live Q&A session where subject matter experts will respond to recent questions from the Home Health, Inpatient Rehabilitation Facility, Long-Term Care Hospital, and Skilled Nursing Facility Quality Reporting Program help desks. If you have questions, we encourage you to submit them through the Q&A box. While not all questions may receive an answer today, CMS will incorporate any unaddressed questions into an FAQs document that will be published on its website in January 2024. Before we begin, we have just a few quick housekeeping items to address. If you experience audio issues on your computer at any point throughout the webinar, you can connect to the webinar audio using a phone by clicking Audio Settings in the bottom left corner of your screen and then switching to Join by Phone. If you experience any other technical issues with the webinar platform today, please try closing out of the webinar and then rejoining through the link you received in your registration confirmation email. If you continue to experience any technical issues, please let us know by submitting a comment or question through the Q&A box so we can assist you. Finally, a recording, a transcript, and the slides from today's webinar will all be available on CMS's website in the coming weeks. So with that said, I will now turn it over to Cindy Masuda from the Division of Chronic and Post-Acute Care at CMS to begin. Cindy?
Thank you. Welcome. I'm Cindy Masuda, the CMS Health Equity Lead for the Post-Acute Care Quality Reporting Program. I'm joined by my colleague, Alex LeBerge, who leads Post-Acute Care Value-Based Purchasing Quality Reporting Programs. I'm also joined by Yuki, the Acumen Health Equity Project Manager. We appreciate you joining us for today's webinar. We start today's webinar with the frequently asked questions. Next slide, please. And next slide, please. We start today's webinar with the frequently asked questions sent to us since we published the Health Equity Confidential Feedback Report on October 16, 2023. We divided the questions into 4 topic areas. These topic areas are report basics, measuring health equity, methodology, and using the reports. After we answer these questions under these topic areas, we will answer as many more questions as time allows, including from questions you write to us in the Q&A tab provided with this webinar. With that, we will start the frequently asked questions with the first topic area, report basics. I will now turn to Alex to address report basics. Next slide, please.
Thank you, Cindy. Yes, thank you, Cindy. And I'd like to thank everyone who's attending this webinar today for joining us. And we hope that you find the information provided helpful. As Cindy mentioned, we'll start with answering the frequently asked questions on report basics. Next slide. The first question is, what are the post-acute care health equity confidential feedback reports? The Post-Acute Care Health Equity Confidential Feedback Reports contain confidential information that is being made available by CMS to providers for their reference. Currently, CMS releases 2 separate reports that show provider performance on the Discharge to Community DTC PAC and the Medicare Spending per Beneficiary MSPB PAC measures, stratified by beneficiary, Medicare, Medicaid dual enrollment status, and separately by beneficiary race, ethnicity. Next slide. Which PAC providers are able to access the reports? The PAC Health Equity Confidential Feedback Reports will be available for home health agencies, inpatient rehab facilities, long-term care hospitals, and skilled nursing facilities. It is important to note that different types of providers are not compared to one another. Additionally, a facility agency must meet an across-provider comparison reportability threshold for at least one race, ethnicity, or dual status population. This requirement ensures that all providers that receive Health Equity Confidential Feedback Reports have at least one comparison result populated in their report. If a confidential feedback report, so further details about the reportability requirements will be available in the upcoming methodology report. Next slide. How do I access my report, you may ask? To locate your Health Equity Confidential Feedback Report in iKeys, please follow the instructions listed on the next 2 slides. First, log into iKeys at ikeys.cms.gov using your Health Care Quality Information System, HCQIS, access roles, and profile HARP user ID and password. If you do not have a HARP account, you may register for a HARP ID. From the Reports menu, select My Reports. Next slide. From My Reports page, locate and select the Health Equity Confidential Feedback Report. Displayed for you is a list of reports available for download. Select the report name link to view the Health Equity Confidential Feedback Report data. If there are questions regarding accessing your Health Equity Confidential Feedback Report in iKeys, please contact the iKeys service desk by email at ikeys@cms.hhs.gov or by phone at 800-339-13. For information, please review the iKeys report user manual or visit the Post-acute Quality Initiative homepage. Next slide. Our next topic is the measuring health equity. Next slide. We would like to begin reviewing measuring health equity by defining what is stratification, why is it important. Stratification involves the calculation of certain outcomes separately for different populations. Stratified measure outcomes can provide valuable insight on how different patient populations perform on a given measure. This allows providers to see how the outcomes of their care may differ between certain patient populations in a way that would not be apparent from an overall score, that is, the average score of all beneficiaries. Next slide. CMS chose to use dual enrollment status and race ethnicity for the fall 2023 PAC Health Equity Confidential Feedback Reports. How is the dual enrollment status defined in the report? Well, throughout the report, the term dual eligible or duals indicate beneficiaries who are duly enrolled in both Medicare and Medicaid at any point during their stay. Similarly, the 2 terms non-dually enrolled or non-duals indicate beneficiaries who are not duly enrolled in Medicare, Medicaid at any point during their stay. What is race ethnicity group are shown in the report? What race ethnicity group are shown in the report? The race ethnicity categories shown in the report are Asian American, Native Hawaiian, Pacific Islander, Black, Hispanic, white, and non-white. The non-white group: American Indian, Alaskan Native, Asian American, Native Hawaiian, Pacific Islander, Black, and Hispanic populations. Results for American Indian, Alaskan Native patients are not shown separately in the report because of limited sample size and the accuracy concern that was determined during the testing of the metric. Next slide. Research suggests that certain social risk factors, such as having a low income background or being of a particular race ethnicity, may be associated with an increased risk of poor health outcomes. Dual enrollment status is used as a stratifier for health equity confidential feedback reports because research has shown that beneficiaries who are duly enrolled in Medicare, Medicaid tend to have more complex needs compared to those who are eligible for only one program due to age, disability, or low-income status. The CMS stratified measure outcomes by race, ethnicity in the health equity confidential feedback reports in order to better identify differences in the variations in the quality of care received by patients with different racial and ethnic backgrounds. Next slide, please. Which measures did CMS choose to stratify in the fall 2023 PAC Health Equity Confidential Feedback Reports? First is the discharge to community measure, which presents the rate of a successful discharge to the community, with successful discharge to the community including no unplanned rehospitalizations or death in the 31 days following the discharge from the PAC setting. In the reports, it is measured with a percentage rate called the risk standardized DTC rate. The Medicare spending per beneficiary measure spending during the PAC treatment and 30 days after. In the report, this is measured as average dollars amount, called the average MSPB amount. The DCC PAC and the MSPB PAC measures are important, valid, and reliable cross-setting PAC QRP measures. They capture important patient outcomes and efficiency of care. For more information of how these measures are calculated for the health equity report, please see the methodology report. I will now hand it off to Yuki for the next set of questions. Thank you.
Thank you, Alex. Next slide, please. This next question asks about the data sources that CMS used to calculate the results. Speaking first about the measure data, the fall 2023 reports are based on data from calendar year 2021 to 2022 for the home health setting and fiscal year 2021 to 2022 for the IRF, LTCH, and SNF settings. Next slide, please. To speak a little bit more about the other data sources, CMS used data from a couple other sources to generate the health equity confidential feedback reports. For example, CMS used Medicare Part A and B fee-for-service claims to calculate DTC and MSPB measure outcomes and conduct risk adjustment. Additionally, CMS used Medicare enrollment database data to determine beneficiaries' dual enrollment status. Lastly, CMS used the Medicare Bayesian Improved Surname Geocoding MBISG method to identify beneficiaries' race and ethnicity. The MBISG is an imputation method that was designed for CMS by the RAND Corporation to indirectly estimate beneficiaries' race and ethnicity. This method is used in many CMS initiatives, including the PAC Health Equity Confidential Feedback Reports, due to its high validity. Next slide, please. Now we'll move on to talking about your questions related to the methodology of the report. Next slide, please. This question asks about the across and within comparisons that CMS included in the reports. The reports include two broad types of comparisons, which provide a comprehensive summary of differences in care, which are called the across and within provider comparisons. I'll explain each of these comparisons at a high level today, but please feel free to refer to the educational webinar recording that was posted on CMS's PAC QRP training websites to see a full walkthrough of the comparison methods. Now, on this slide, we've included a few figures to help depict each of the comparisons. The building icon indicates your facility or agency, whereas the US map icon indicates facilities and agencies nationwide in your care setting. We also have different colored human-shaped icons indicating different patient populations included in a given comparison, such as duals and non-duals. So to get started with the left-hand side of this slide, the across provider comparisons compare a given provider to all other providers across their same care setting. So for example, your LTCH would be compared to all LTCHs nationwide. And I'm using LTCHs in my example here, but the same concept applies to home health agencies, IRFs, and SNFs as well. And in the reports, CMS provides two across provider comparisons. The first, on the left top portion of this slide, compares your facility's patients to the national performance among all patients. So for example, outcomes for duals at your LTCH are compared to outcomes across all LTCH patients nationwide. And then the second, on the bottom left of this slide here, compares your facility's patients to the national performance among the same population. So using the same example, outcomes for duals at your LTCH are compared to outcomes among duals in LTCHs nationwide. And now that we've touched on the across-provider comparisons, we can look at the last comparison on the right-hand side of the screen. The within-provider comparison examines differences in the quality of care by comparing outcomes for stratified patient populations within the individual provider's care. Here, CMS calculates differences in outcomes between two populations at your facility, such as between duals and non-duals. Next slide, please. So this next question asks about the set of results that CMS calculates for each of the comparisons I just spoke about. To answer this question, CMS produces 3 results for each of the comparison types, which are the difference that is examined in the comparison, the confidence interval of the difference, and the category of the difference. To speak a little bit more about each of these, the difference specifically refers to the difference in measured performance between the two groups examined by a given comparison. For example, one of the differences that CMS calculates for the within provider comparison is the difference in measured outcomes between a given facility's dual and non-dual patients. For example, this might show that duals had a lower or worse discharge to community rate than non-duals at a given facility. Then CMS also calculates a 95% confidence interval for each difference, because the difference alone may represent a result that is due to random chance. And a confidence interval is a range around the difference that conveys how precise the calculated outcome difference is. In this case, the confidence interval indicates that we are 95% confident that the true difference in measure performance falls within this range. Lastly, CMS then determines categories of the difference to describe whether a given facility's patient population is performing statistically significantly better than, worse than, or no different from the comparison group. To do this, CMS uses the upper and lower bounds of the 95% confidence interval to make those categorizations. For example, if your report included a result that indicated worse outcome for dual patients at your facility for a within provider comparison difference, this means that the outcome among duals at your facility was statistically significantly worse than outcomes among non-duals at your facility. Next slide, please. Next question is, how does CMS identify providers in similar geographic locations? To provide a little bit of context here, providers may have noticed that some of the tables in the reports show results for providers in similar geographic locations as you, such as the same rural or urban location, the same core-based statistical area, the same state, or the same region. CMS included this information on patient outcomes among facilities in similar geographic locations as you to give providers an idea of how providers located in similar areas performed. In terms of the data sources, CMS obtains facility and agency rurality and core-based statistical area information from the provider of services file for hospital and non-hospital facilities. This is a publicly available source that contains various pieces of provider characteristic information. Next slide, please. This next question asks about how CMS identifies providers with similar patient composition. Similar to the context for why CMS included results for providers in similar geographic locations, CMS included these results to give providers an idea of how facilities and agencies with similar patient composition as them performed on stratified measure outcomes. Here, CMS used 3 characteristics to determine the patient composition groups shown in the reports, which are patient risk brackets, proportion of duals, and proportion of non-white patients. I'll briefly explain each of these 3 concepts. First, the patient risk brackets allow CMS to group providers based on average clinical complexity or risk of patients within the facilities and agencies. CMS groups each provider into 10 risk brackets based on the average clinical complexity of patients within the facilities and agencies. CMS uses expected outcomes from the measure risk adjustment model when calculating the patient risk brackets. Next, CMS calculates dual enrollment quintiles to determine facilities and agencies with similar proportions of dual patients. CMS does this by calculating the proportion of stays or episodes at each facility that are attributed to dually enrolled patients. Then CMS calculates dual enrollment quintiles so that quintile 5 includes providers with the highest proportion of duals, while quintile 1 includes providers with the lowest proportion of duals. CMS also calculates non-white patient quintiles following the same approach to determine the set of facilities and agencies with similar proportions of non-white patients. As noted here, CMS will release a methodology report in January, which will provide these step-by-step calculation details for each of these concepts. Now I'd like to hand it over to Cindy to cover the next few questions.
Thank you. Next slide, please. So now we're going to be talking about frequently asked questions related to using the reports. Next slide, please. So the first question is, in this category, is how can the post-acute care providers use the health equity confidential feedback reports? The health equity confidential feedback reports are intended for providers to give them feedback about their performance for certain populations who may have been historically disadvantaged. These reports are meant to provide information to providers and identify opportunities for providers to focus their internal quality improvement initiatives so that all individuals have their best opportunity to achieve the best potential health outcomes. Next slide, please. What are CMS's long-term plans for these reports? CMS plans to release the post-acute care health equity confidential feedback reports to providers on an annual basis. We are continuing to explore the potential of expanding these confidential feedback report approach to other measures and other social risk factors and/or demographic variables for future reporting. Additionally, we are also exploring the use of post-acute care assessment data as a source for social risk factors and demographic variables as such data become available. Next slide, please. So if you would like more information on the post-acute care health equity confidential feedback reports, people had asked where they could locate that. And we have provided many resources, and these include resources that we posted in October of 2024, and those include the Health Equity Confidential Feedback Reports fact sheet and the Health Equity Confidential Feedback Reports for Post-Acute Care Education Outreach webinar. Today's webinar on Health Equity Confidential Feedback Reports for Post-Acute Care Questions and Answers webinar. The recording for this webinar will also be posted on our provider education and outreach website. And then in January of 2024, we will also be posting frequently asked questions document and the methodology report. Both those reports, as I said, will be posted in January of 2024. You can find all these materials on the provider-specific training sites for home health, inpatient rehab facilities, long-term care hospitals, and the skilled nursing facilities provider training websites. Next slide, please. And so where can I share feedback with CMS on the usefulness of the post-acute care health equity confidential feedback reports? We really appreciate this question because we welcome your feedback to the health equity confidential feedback reports. Please submit any feedback to your provider-specific help desk. So for home health, it's the home health quality questions at cms.hhs.gov. For IRF, it's the IRF.questions at cms.hhs.gov. For long-term care hospitals, it's the LTCH quality questions at cms.hhs.gov. And for skilled nursing facilities, it's the SNF quality questions at cms.hhs.gov. And please make sure you include in the subject line health equity feedback in your email so we know that that's the purpose of these emails. And with that, I will turn back to Yuki to open the webinar up to the written questions and answers. Thank you very much.
Great. Thank you, Cindy. Thank you all for listening to the presentation portion of today's session. It looks like we've received some questions through our help desk inboxes as well as through the Zoom Q&A features today. So thank you all for submitting them. We'll go ahead and now start answering some of those questions. As noted earlier, please note that we may not be able to answer all of the questions today, but we will make sure to review all of the questions after the webinar and incorporate them into the upcoming FAQ document as needed. So with that said, I'll start going through some of these questions. Cindy, I'd like you to take this first question, which asks, why didn't my facility receive a report or a certain result in the report?
Okay, appreciate that question. So a facility has to meet specific reportability thresholds to receive certain comparison results in the report. For example, for a facility to receive a result for the within provider comparison by dual status, they must have at least 10 Medicare spending per beneficiary episodes for dual patients and 10 Medicare spending per beneficiary episodes for non-dual patients. Additionally, in order to receive a health equity confidential feedback report, a facility or agency must meet the across provider comparison reportability threshold for at least one race and ethnicity or dual status population. This requirement ensures that all providers that receive the health equity confidential feedback report have at least one comparison result populated in the report. And in addition to this explanation, the requirements are described in further detail in the upcoming methodology report that's going to post in January of 2024. Thank you.
Great. Thank you, Cindy. We have a couple questions actually related to more specifics about the across provider comparison. So I'll ask you, Cindy, for both, but one at a time. First, can you explain again the difference between the two across provider comparisons in the report?
Sure. So for this question, if we could look at slide 17 again, as we talk through this question. Thank you. So the first across provider comparison compares the measure outcome among a specific population at your facility. So as Yuki was talking about before, as an example, your long-term care hospital duals compared to the national performance across all patients in your care setting, such as all long-term care hospital patients nationwide. That's the first one in that in slide 17. In contrast, the second across provider comparison compares the measure outcome among a specific population at your facility, such as your long-term care hospital duals, to the national performance among the same patient population in your care setting. So that could be like all duals in the long-term care hospitals nationwide. Thank you.
Thank you for that question and answer. And the next question is related. It's a follow-up to this. Could you please talk about why CMS chose to use the two across provider comparison methods? Cindy, could you also answer this one?
Sure, that's a great question. So CMS chose to use the two across provider comparison methods because they serve different purposes. Like we mentioned previously, the first method allows providers to see how their specific population performed relative to the overall national average. And then the second method further allows providers to see how their specific population performed relative to all providers of the same population in their care setting. It's possible that a provider's patient performed well relative to one national comparison group, but not the other. So that's the benefit of having both comparisons. CMS we hope that by providing both comparison results, we help equip providers with more information that they can use to better understand their population performance so that you can develop effective internal quality improvement initiatives. Thank you.
Great, thank you. I'm also seeing a couple questions too about the within provider comparison. So while we have the slide up, Alex, I'll have two questions for you. The first is, can you explain again what the within provider comparisons are? Why is it important to see those results?
Thank you. That's a good question. The within provider comparison is important because it identifies the differences in the quality of care by comparing the outcomes for stratified patient populations within the individual's provider's care. The within provider comparison calculates two sets of the measure performance differences between the following two combination of patient populations: patients who are duly enrolled and patients who are not duly enrolled, and patients who are non-white and patients who are white.
Great, thank you, Alex. A more detailed question, it looks like, for the within provider comparison, Alex. Can you provide an example interpretation of the within provider comparison results?
Sure. A positive DTC rate difference for the within provider comparison of the duals and non-duals signifies that the duals in the facility, in your facility or agency, higher DTC rate, which would appear as better performance than the non-duals at your facility agency. A positive average MSPB amount difference for the within provider comparison of duals and non-duals signifies that the duals at your facility or agency have a higher average MSPB amount or being a worse performance than the non-duals at your facility. As you can see, that the different measures can have different directions based on the structure. The within provider comparison provides your SNF, home health, IRF, or LTCH with insight on the care that you provide to the different populations to help your facility as you work to provide the highest quality care to all the patients you care for. Thank you. I think that's it.
Great. Great questions, and thank you for the answer, Alex. Cindy, I'd like you to answer this next one. Can you clarify what race and ethnicity groups are shown in the report?
Sure. So the race ethnicity categories shown in the report are Asian American, Native Hawaiian, Pacific Islander, Black, Hispanic, white, and non-white. The non-white group consists of American Indian, Alaska Native, Asian American, Native Hawaiian, Pacific Islander, Black, and Hispanic population. Results for the American Indian, Alaska Native patients are not shown separately because of limited sample size and accuracy concerns during testing. So they're grouped in the non-white category. Thank you.
Great. Thank you, Cindy. For this next question, if you could answer this again, Cindy, why did my facility not receive a geographic location related result within the report?
Sure. So a given geographic location, such as your core-based statistical area or CBSA, or your state or your region, can show as NA, not applicable values, if your geographic location didn't meet the reporting threshold. That's the minimum of 10 facility or agencies with reportable comparison results. Or if there was no data available on your facility's geographic location. And then the other way is if your CBSA, your core-based statistical area column, is not populated with data, it's because your facility is located in an area outside a metropolitan statistical area, meaning it's a rural area. And again, we have more details about this in the upcoming methodology report that will be posted in January of 2024. Thank you.
Thank you, Cindy. This next question is for you, Alex. How does CMS calculate those patient risk brackets for the comparisons to providers with similar patient composition?
That's another good question. Patients' risk brackets allow CMS to categorize providers based on the average clinical complexity or risk of the patient within the facility agency. CMS calculates a risk bracket using the following steps. CMS calculates a risk score for each DTC stay or MSPB episode that indicates the complexity of your patient. The risk scores are calculated as the expected DTC rate or the MSPB amount as predicted through the measures risk adjustment model. CMS then calculates the average risk score. This is the average of the risk scores for all the DTC stays and MSPB episodes. Finally, CMS creates a distribution of the average risk score across all providers in your care setting. CMS divides the distribution into deciles to create risk brackets with the equal number of providers in each bracket. A risk bracket of 10 includes providers with the highest average risk, while the risk bracket of 1 includes the providers with the lowest average risk. Your risk bracket includes providers who have similar average risk score as you.
Great. Thank you for walking us through that, Alex. And just as a reminder, Cindy mentioned this earlier, but the upcoming methodology report in January will have these information in more detail as well. We have the next question. Cindy, if you could please take this one. Will CMS continue to produce these reports every year?
Thank you. So CMS plans to update the post-acute care health equity confidential reports annually after this past fall 2023, and is continuing to explore the potential of expanding the confidential feedback report approach to other measures and other social risk factors for future reporting. And as we talked about, we really welcome your feedback on these post-acute care health equity confidential feedback reports so that we can take your comments into consideration for future reporting planning. If you have any feedback, please submit it to your provider-specific help desk email, which was listed on the last slide of our presentation. Thank you.
Thank you. Okay. Thanks, Cindy. I'm looking at the time here, and it looks like we have time for just one more question before we wrap up today's webinar. So Cindy, if you could please wrap us out by answering this final question. Will these reports be made publicly available?
So the 2023 Post-Acute Care Health Equity Confidential Feedback Reports, they are strictly confidential and released to providers for their reference. It's a reference-only document. Our intention behind releasing these reports is for the providers, the SNFs, IRFs, LTCHs, and home health agencies to use the results to develop strategies or quality improvement programs to reduce the negative impacts of social risk factors on measure outcomes for their patients. Results from the 2023 Post-Acute Care Health Equity Confidential Feedback Reports do not impact public reported quality program scores or provider reimbursement. And I can't emphasize that enough. So thank you for that question.
Great. All right. Thanks so much, Cindy and Alex, for your answers. And thank you as well, Yuki, for moderating today. But as Yuki has alluded to, those are all the questions that we do have time for today. So we're going to go ahead and conclude the Q&A here. Actually, Claire, would you mind going back to slide 25, please? Great. Thank you so much. Okay, so, as Cindy mentioned earlier in the webinar, in January 2024, CMS is going to be publishing an FAQs document on its website. So if your question wasn't answered during today's webinar, we do encourage you to submit your question to one of the 4 provider-specific help desk email addresses that we have listed here on this slide. And we are also going to post the email addresses in the chat box in case you'd like to copy them down. We're actually going to pause here for just a few seconds to give everyone an opportunity to copy the email addresses down if you'd like. Great. Okay. So, Claire, do you mind going up to slide 27, please? All right. Thank you. So the FAQs document I mentioned is going to be published on the Home Health, IRF, LTCH, and SNF provider training web pages on CMS's website. We did share the links to those 4 web pages in the chat box, so we do encourage you to copy those links if you haven't already done so, and then bookmark those pages. And then in addition to the FAQs document, recording, a transcript, and the slides from today's webinar will also be published on those 4 pages within the next 1 to 2 weeks. All right, so that concludes today's webinar. Thank you, everyone, again, for joining us today, and we hope you all have a great afternoon. All right, bye now.